we are well aware that the population is increasing from 2.5 billion when I was born in 1950. Another 100 years later, we have 9 billions. And when you look at this graph, then you see the proportion of the people 65 or older is increasing substantially. And as it is the 20 to 64, and the group of 0 to 19 is decreasing. So we have to do something for the elderly, and this is also addressed in this publication. The global burden of dementia on this slide, which have been put together in a Nature publication, it's a worldwide approach, looks at different parts of the world like North America, Europe, Asia, Central South America. When you just take the figures for South and Southeast Asia, you see in 2010 there are 7 millions, then 14 millions, and by 2050, 29 millions. So the increase is substantial, as it is in North America or in Europe. So worldwide, there is a global burden of dementia, and we need to be prepared for this global burden. Let's look at the physiology of aging and cognitive decline. So you have the aging process, and you know it from different parts of the body which get older, but also the brain unfortunately gets older. Then we have the mild cognitive impairment. Sometimes you find also in my presentation very mild cognitive impairment, and then starts dementia with a loss of neurons, and there's a threshold, a dementia threshold, when the symptoms start to reappear. And you very likely know that they usually start first with behavioral symptoms and later then also with other symptoms. I will go to this. And the fading of memory, fading of concentration, the proneness to stress, and the impaired performance are factors of mild cognitive impairment and also the developing of dementia. What are the risk factors of the etiology of a pathology of cognitive decline and dementia? Several factors have been discussed and are not the main topic of my talk, which is more on the clinical parts, but I think we need to be aware that genetic factors, then apoptosis, cell death and cortical atrophy, metabolic disorders, depression including insulin resistance, enduring hyperactivity of the HPA axis, then age, oxidative stress, mitochondrial damage, and vascular factors like hypertension, atherosclerosis, stroke, white matter lesions. All of them are factors which finally result in cognitive decline, then mild cognitive impairment and dementia. It's not a single factor, but we know that like vascular factors and metabolic factors, of course, contribute very much to the vascular part of dementia, which is usually associated with dementia. And those people who do something for their vessels and do something for their metabolic state, they do already very good, not developing dementia. Genetic factors, of course, we cannot influence, but we make them worse when the metabolic and the vascular factors, they pull in. With depression, on the other hand, it's pretty much the same. So we have to take care of depression, because also depression, you know, is a hyperactivity of the HPA axis, hypothalamus pituitary adrenal axis, and the hippocampus and the other parts of the brain. They really do not like high cortisol levels, because this causes the shrinkage of these parts of the brain. With the next slide, you see the behavioral and psychological symptoms associated with dementia. You see on the one hand side the psychological symptoms, on the other hand the behavioral symptoms, and usually dementia is thought to be only included by cognition, but we know very well that the psychological symptoms can be part of like psychotic symptoms, hallucinations, delusions, misidentifications, affective orders start early, like depressive symptoms, anhedonia, hypomania, apathy, lack of interest and motivation, as well as anxiety, like phobias, compulsions, catastrophic reactions, or factors of general anxiety disorders. The behavioral symptomatology include like inappropriate sexual behavior, sleep disorders, or agitation, physically, verbally aggressive, non-aggressive behaviors, opposition, wandering. All this symptomatology, of course, we have to differentiate from other diseases like depression or other forms of dementia, but they go together with the picture of cognitive decline, very mild and mild cognitive impairment. It's quite prevalent in the community, like depression, apathy has the highest point prevalence, as you see here, and also in the 5-year prevalence rate, this is quite high. But you see also when the disease progresses, then you have, like in the 5 years prevalence rates, higher rates of delusions and hallucinations. Behavioral and psychological symptoms, they are sometimes also termed neuropsychiatric symptoms, which cover the same symptomatology which I just have alluded to you before, and they include like the non-cognitive behavioral psychiatric symptoms, which I alluded to you before: disturbances of mood, perception, anxiety, agitation. You see, these neuropsychiatric symptoms, it's just a terminology. So they are the same like BPSD, and they can be measured with the neuropsychiatric inventory, the NPI, which you see some data later, or the geriatric depression scale. On the next slide, you see that neuropsychiatric symptoms are common in mild cognitive impairment, MCI, how I abbreviate it, and dementia. Like 43 to 50% of MCI had NPS, neuropsychiatric symptomatology, depression, apathy, irritability, most common, and the prevalence of apathy, agitation, and irritability are higher in amnestic MCI than in non-amnestic MCI. 75% of dementia had one neuropsychiatric symptomatology, 55% had two, 42% had three neuropsychiatric symptomatology. Again, like apathy, depression, agitation are most common. And the profile of symptoms, subtypes, and risks are fairly homogeneous across Western and Asian cultures. There is no much difference, has been pointed out in this publication of Yatavara recently in 2018. The significance of neuropsychiatric symptoms in cognitive impairment is insofar important because they predict cognitive decline in cognitively healthy elderly. The subjective cognitive decline, as abbreviated SCD, you see in next slides also, and anxiety increase the risk and shorten the time to MCI and dementia. If subjective cognitive decline, SCD, and anxiety coexist, the risk is much higher compared to either problem alone. So you probably know some friends, elderly friends, they say, well, my cognition is not so good anymore. And when they come then to the doctor, if the doctor sees the cognition is not that good anymore, if they also find anxiety, they could make a mark that the dementia could happen in the amount, as I mentioned before, and very likely and good to give some medication already to prevent this decline. So NPS, neuropsychiatric symptoms in MCI, predict prognosis and progression to dementia, and needless to say, the NPS are associated with increased caregiver burden when you think about depression, anxiety, or even hallucinations and paranoid symptomatology. To mind also what I just presented to you, how neuropsychiatric symptoms in MCI may predict progression to dementia. You see here a meta-analysis plot of neuropsychiatric symptoms as predictor for MCI conversion to dementia. Then you see that a number of studies, like if you combine them, indicate that this is can be considered as a predictor. The caregiver burden is quite substantial, as I mentioned before, and there have been several publications on this. And like this one study, the Zarit burden inventory was completed in 177 patients, and it showed that the caregivers, in a percentage of like 29%, they reported increased burden during the follow-up period between 1 and 3 years. And each point increase in the NPI score was associated with a 0.3 point increase in the Zarit burden inventory, the CBI score. The standardized effect size was 0.4, and compared to the functional impairment was minus 0.2. So this, of course, is known to the practitioners, but has been substantiated also in this scientific publication. So giving you the picture of MCI and also dementia, the symptomatology and the caregiver burden, the question, as it is on my introductory slide, how does EGB 761 fit in? And I would like to remind you once more on the spectrum of cognitive disorders, which goes from normal aging to subjective cognitive decline to mild cognitive impairment, and then to dementia. It's a pretty much same slide as you saw before, on a different scale, in a kind of a categorical scale, that we can also then better understand the studies which have been carried out in MCI or very mild MCI, or in normal aging, and finally in dementia. So let's start with the normal aging, which is termed here before MCI, in cognitively healthy volunteers. And what you see here in the test of prospective memory, they have a higher rate when they took the EGB 761. And interestingly, in the driving route recognition memory, there was no difference. But in the prospective memory, part of the memory, you could find the effect already statistically significant, beneficial for EGB 761 in this study by Kaschel. Another study, it's before MCI, normal aging in cognitively healthy volunteers. They have different kind of measurements being undertaken in 262 cognitively intact older adults. Older starts with the age of 65, unfortunately, and you see there are statistically significantly effects also when they are cognitively intact. So you have higher rates and better rates in delayed free recall and delayed recognition, and also the Wechsler memory scale number 3 with faces, which they should remember, have significantly better rates for the ginkgo treatment EGB 761 than the placebo condition. I specifically would like to mention that we should not talk only about ginkgo, because there are so many preparations out there in the field. And when I talk about ginkgo, I always be reminded that it's EGB 761, which is a standardized extract, also conducted by company Schwabe. This is very important to differentiate from other extracts which have never been tested so rigorously in clinical praxis. So which randomized placebo-controlled trials are available in the next step? Mild cognitive disorder. Just to remind you, before I was talking about normal aging. Now we talk about mild cognitive disorder, MCI, you see a number of studies carried out already from the 80s, then 90s, and I will present to you the last two from Kesehatan from 2011. They took a subgroup of very mild cognitive impairment and defined them, and Gavrilova, they did the study including the neuropsychiatric inventory, whereas the first study, which I show you, only looked at cognitive points. So let's start first with the Kesehatan study, where they looked in very mild cognitive impairment, and they looked on the effects of EGP 761 on cognition and quality of life in subjects with very mild cognitive impairment, a number of 300 subjects aged from 45 to 65, and you see the mean age in both groups was pretty much the same, around 55 years of age. They reported cognitive complaints and were more than one standard deviation below the appropriate norm in at least one cognitive test. They were double-blind treated with either EGP 761 or placebo for 12 weeks. They included also the Vienna test system, which we developed in Vienna here, which has different work performance series included. And when you look here, the mini mental state was around 27, which also speaks for this very mild cognitive impairment and not for dementia. And also the BFS is the Befindlichkeitsskala, that what means like how you feel today is in a very low level. So what is the outcome? The outcome showed in this group of very mild cognitive impairment a significant improvement of EGP 761 in measures of attention. That's the upper scale. And then trends in favor of EGP 761 in measures of memory recall. That's Wechsler memory 3, delayed recall. And the cognitive effects were more pronounced in subjects with lower baseline memory function. So the total sample differentiated, and the more impaired patients showed also a specific better response. So the conclusion from this study is that EGP 761 improves both visual and prospective verbal memory, free recall and recognition under immediate and delayed conditions. It improves attention and concentration, quite importantly, and the patients always tell me, like recently was a lawyer in my practice, and he said, well, this medication is interesting, I am much more alert and I can do my work better, which was not that good before. He was very likely in this group of very mild cognitive impairment. And the effects are more pronounced, as one can assume, in subjects with more distinct cognitive impairment at baseline, and the factor of physical health, of healthy related quality of life, was improved by the treatment.